Good evening, it's Dr. Duke Majan. We are starting our last surgery for the day. And last but not least, one of my favorite patients. So Dr. Patel has already had his way with her. He did her RFA because she needed it. She has some facet pain and we've treated that. Now we're going to treat her disc problem. She's got a bulging disc at L3-4 and two degenerated discs at L4-5, L5-S1, causing her back pain and leg symptoms. All right, you've been through this before, but last time it was your neck and you were asleep. So you're going to be awake in the beginning, okay? Then we're going to put you to sleep. Are you comfortable right now? All right. I'm going to give you a little bit of numbing medicine, okay? So we're left 4, 5, 5, 1. That's my hand back there just touching you. I'm feeling around, okay? So if you have any pain, just say ouch, and I'll give you some numbing medicine. I know. That's just numbing medicine going in. I apologize. Do we try any bicarb?
No, this one, sir.
Next time?
Yes, sir.
All right, he said it was a 10%. Yes, right, 10% bicarb? And left, we said, was 4, 5, 5, 1. Right is 3, 4. Is that correct?
Yes, sir.
Right? We're all in agreement? I know. Okay, so our patient, we're going to be fixing 3 discs. And Diego, do you want to run the animation?
Yes.
Showing how herniated and bulging discs cause back pain. This is one of our new animations we've just created.
Traumatic injury to the disc can cause annular tears to form.
It's important you lay still and don't move around. Just let us know what you need us to do and we'll take care of it.
Pressure on the disc causes herniation of the nucleus pulpus through the annular tear.
Shot. Lateral.
Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals.
Now we're going on both sides.
Additional injuries can cause symptoms to worsen.
Shot has problems with discs on.
Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain.
Basically leg symptoms on both sides. So our goal is to treat those.
Signals travel up nerves to the brain, causing localized back pain.
I need to see 5-1 first.
Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Shot. Huh? Music? Where's the music? You're right, I forgot about it. They're cheating me, my staff, on the music. Shot. We need to get the music going. Shot. I could sing for you. Let's get an AP. I'm like the worst singer in the world. At least that's what my kids say. My kids say that I'm tone deaf, which I probably am. Man, I don't know how you got that lateral, but that is absolutely amazing. Like I say, better to be lucky than good. Hey guys, not too close. That looks good. Go back to a lateral. What were you saying? No. You'll get it. Everything's going good, okay? Need to be further south. So do we really not have any music? We used to have Sirius XM. Well, we got to connect it to the overhead. How do we do that? Wish we had Sunny. Anything? Are you feeling anything? Shot. So that's pretty darn good. We don't have a pseudo disc, I don't think, right? Let's see. Yes. Make my job easier. Oh, do we have the MRI up? No? Can we do that? Shot? 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 Huh? What am I saying? Shot. Shot. It means take a picture. That's what I say. That's my thing. Huh? Just watch behind you guys. Don't get too close to the table. Well, that is unfortunate. Oh, there we go. Huh? I'm getting into your L5S1 disk space, and you're not making it easy. That is for sure. But I have a great technician. Let's go 4-5. Are you comfy? All right. Uh-huh. Our last patient is doing fantastic, by the way, for those of you wondering. So, Diego, did you show the audience?
Yes, we showed the video.
The video that shows how the annular tear gets inflamed after the herniation occurs, after the annular tear occurs.
Yes, we did.
And that's the source of back pain. I think we need to do a little bit better. That's close. I don't know. I'm okay with that if that's all we've got. I think that's worse. Now that's a good song. You know that's my wedding song. Yeah. Shot. Yeah, that's my wedding song. Luis, what do you think? Look at that facet. It is huge. Shot. No wonder why she has facet pain. We're just admiring your arthritis. Shot. Who else can say that, right? But a spine surgeon operating on your back. Where do you feel that? How far down? All the way to where? Your foot? All right. That's what I need to know. Shot. Is it better? AP? Don't wanna close my... So the first step of this surgery is to gain access to the part of the disc that's actually causing all the pain. And it's always in the back. Actually, it looks pretty good. Let's go back to a lateral. want you to really get in on that 4-5 disc. One more time. Let's see if we can get those pedicles slightly better. I honestly think that looks pretty darn good, but see if we can get those pedicles slightly better. I'd say a degree of wag one way or the other. I don't know, I think that's worse. Try the other way. Is that really all we can do on the music? That? Well, I'm just thinking, we can't play it overhead? Nobody knows how to do that?
There is a cable down there. I probably white down there. Yeah.
Shot?
White. We need the white cable. I think or that attached to the phone. I don't know. I think it's a white cable around there.
Where do you feel that? Not down your leg, Shot. Shot. What? But just your back and your but not down your leg. Not down your leg? Shot. Huh? I gotta hear. I gotta know what she's saying. But not past your knee. Correct? I'm on that. That is a big bone spur. Shot. In your back, right? Huh? I don't know what she's saying. Just relax. I don't want you to ask me too many questions. I need you just to help me get to where I need to go, and then everything will be good. Shot? We're not doing any dye yet. Huh? Of course I know you're a nurse. No, you're fine, but let me just focus right now. Shot? These two discs, the bottom two, are really going to be tough because they're so collapsed. I got the bottom one, which is the worst. This one here, I'm still working on. But you're doing great. I just need you to relax your back. Huh? Shot? All right. So... Shot. AP. You're doing good, okay? Everything's fine. I promise. The only reason it's taking me a little longer than normal is these two discs are just so collapsed. But I know they're still causing you pain, so I want to make sure we get them. All right, lateral. That's all looking good. 3-4 will be a lot easier to do. And those lines, if you're wondering what they are, they're just the Raytec. You guys see those lines on the x-ray? That's this thing right here. It's a thread in the Raytec. And so you never leave a sponge in a patient. You can always see them. All right. It's actually moving, believe it or not. When she relaxes, you can feel it moving. Shot? All right. I'm just curious. How much progress we made. Shot? Yeah. How bad is that on a scale of 1 to 10? 8. It's just leaking out. There's a disc is totally incompetent. AP. What? Right. I understand. All right. Yeah, I know. It's all that lifting of patience, right? So we know for sure L45 was a 8 out of 10. Okay? Where's Rita? L45 was an 8 out of 10. Don't move around too much, okay? How bad is that on a scale of 1 to 10? Huh? 10? Is that where you get your back pain? Isn't that amazing? There's like no disc left, 99% collapse. Just relax, you're fine. I apologize. You said it was a 10? Let's go to a lateral. Once again, the dye isn't even staying in the disc, it just leaks out. That's 4551. So 8 out of 10 for 45, 10 out of 10 for 51. Concordant. Let me get a picture, get an x-ray. Again. Jeez. Yeah. Nothing. Isn't that amazing how it just spilled out? All right. No. Are you okay? You feel shaking? Why are you shaking? Are you cold? All right, well, just relax. We're almost done, okay? We're almost done. Num num. We're going to put you to sleep soon. We haven't done 3-4 yet. We're about to. Just lay still. You're fine. You're okay. I know it's a bit uncomfortable. You'll be fine, though. Shot. What is it? What is she saying? Yeah, well, we irritated your discs. Those are the ones we're here to fix. Shot. What's that? Just lay still, you're fine. Lay still. You all right? Shot. 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 I have mixed feelings. Let's go AP and see where we are. You're doing great. We are almost done. We're going to put you to sleep in about 5 minutes. All right? Quick shot. Yeah, we're pretty darn close, so I think we're okay. Let's go back to a lateral view. It's got a little scoliosis there. You see the offset of the spinous processes between 3 and 4? I'm going to call you a turtle if you keep lifting your head up like that. Your nose is running? All right, you want to wipe her nose for her or something? Yeah. Shot. You okay? You're fine. Don't be nervous. Everything's going well. I promise. You feel that in your back? That's your herniation at L3-4. It's huge. It's actually bigger than you see on the MRI because I'm encountering it right now, and look how far back behind the disc we are. That's amazing. You can actually see it. All right, you comfy? Relax. Don't try to pick your head up. Big tear. All right. Get ready to put her to sleep. We have one more disc to test. With your hat sideways like that, you remind me of the Little Rascals. There's one of them. I can't remember. Is it Spanky? All right. Shot. How bad is that? An 8? Do you typically get that pain? Is that typical pain? Huh? All right. So 8 out of 10. Interesting. A lot of pressure. Definitely herniated. But I'm not seeing a really well-developed tear. You can go to sleep. Yeah, I'm sorry. So 8 out of 10 at 3-4. I think it's just scarred up. But still painful, obviously. I need to see 5-1. That's the first one we're going to do. Will you count out loud for me from 1 to 100, please? Out loud. Keep going. You're doing great. So I'm going to show you what we just did. We, you at 5-1? That's good. All right.
Nice.
So we tested the L5S1 disc, and it was pretty darn collapsed. And then we tested the 4-5 and then the 3-4. What did we say L5S1 disc was? Pain? Was a 10, right? It was a 10 over 10. And then L45 was an 8 over 10 concordant. And L34 was a what? 10? 8 over 10. So, you know, if you asked me which disc would be the most painful, I would have picked the L34 based on the MRI. It just shows you can't trust MRIs. They don't tell you where people's pain comes from. People tell you where their pain comes from. All right. Here we go. We're going to take this needle out and leave the guide wire. Are you awake? So I'm going to need some help getting in. Shot? I need the lights down
This one on.
so I can see. That's good. Oh no, that's bad.
Yes, yes, yes. Thank you.
Shot? There we go. So we're leaving the guide wire in the L5S1 disc space, and we're pulling the needle out. Needle's out. Shot? So you can see the guide wire is still there. It's a skinnier line than the needle because it's smaller. And when you pull, I'm telling you, when you pull the needle off of guide wire, you got to make sure you don't pull the guide wire out too. I've done that once before. Huh? Yeah. So now we're going down with a dilator. Shot. Okay. So the more relaxed we get her, the easier this will be. So far, so good. Shot. We're past the facet joint. We're at the back of the disc. Now I've got to spread these bones apart and open the disc up so I can get in there and with a tube and fix it. And here we go. Slow progress, but really good. Shot. Yeah, making progress. Let me just see. I'm going to pull the guide wire back a little bit. Or a lot of it. We need the coker. Mm-hmm.
I need another guy one, please.
Yeah, go ahead. Thank you. Good job. Shot. Beautiful, Luis. Beautiful. You are the man. You know, surgery is not a one-man or woman show. It's really a team effort. No, I'm not ready. Shot. So, shot. So of course,
Another standby.
you know, one thing we know about this disc is since it's so collapsed and arthritic, it's going to be very inflamed end plates. Once the jelly and the nucleus is for the most part gone, all you have left really is the, all you have left is inflammation on the end plates and a small amount of an annular tear that's inflamed. So we're after the annular tear. We're not after the end plate inflammation. But, shot, we're going to see it for sure. Some bleeding end plate. It's inevitable when you have this advanced arthritis in the disc space. Yeah, I know. That should be good. We knew this wasn't going to be easy, shot. Oh, perfect. Wow. All right, let's pull the fluoro out. Straight back with the fluoro. So for those of you who've never seen the surgery before, this is a Duke laser disc repair. It's a specific type of surgery because of what I do in the disc. But all this part, making the incision, going from the side, putting a tube, it's all pretty standard endoscopic surgery. I'm doing an L5S1 right now. Most surgeons, there's not many endoscopic surgeons in the world, but they don't do L5S1 because they're unable to. They go intralaminar, translaminar, so they actually remove bone. I don't do that. I don't think it's necessary or advisable. And they don't treat things like this. They treat soft herniations that are compressing the nerve root. I treat the annular tear. Yeah.
One second, no. The fiber is outside. You see the fiber? It's in my hands.
The fiber? You mean the fiber or the fiber? Fiber is something my son is always spending money on.
What is that?
Laser. It's called Fiverr. It's a site that they do work for you. Yeah, that's what my wife and I have to say. Huh?
That's what happened when you daydreaming.
All right. Let's see. Beautiful. Like he started a 501c3, a nonprofit. And
Lights off, please.
he has them building content for him, like making the website and stuff.
Oh, that's nice.
Yeah.
That's very smart.
Yeah, he doesn't know how to make a website, so he has them do it for him.
So that's smart.
Well, you pay people to do tasks like that, like build websites or make PowerPoint presentations, whatever. We are at the L5S1 disc, and you can clearly see back here there's a tear. There's really not a lot of disc left at all. It's really almost bone on bone, but there are some bone spurs here that I'm getting rid of with the laser right there. That's a bone spur. And it's right where the nerve is, just underneath it. So there's some old chunky herniation, which we'll grab with the grabber because it's not going to float out. More bone spurs. The oozing is just from the end plates. I told you we'd see that. Anytime you have a totally collapsed disc that's inflamed, the end plates get red and inflamed. They'll ooze a little bit, little bit of blood. But this is what we're really after right here. This is the back of the annulus. It's where the tear is, and it's the source of her back pain. And zapping it away is going to get rid of that pain. And we tested her disc, and she had, I can't remember, either 8 or 10 out of 10 pain at this level. But she had already had the facet rhizotomy done by the time I got in here. So we know that she still had pain from the disc. Otherwise, if it was from the facet joint and I did the discogram and the facet's already been treated, then she wouldn't have any pain. But she did have pain because she actually had pain from the facet and the disc. So we did both. Dr. Patel treated the facet with a rhizotomy before I got in here, and I'm doing the disc treatment with the laser. Any questions from our audience?
No, sir.
No. Thank you. Again, this is a live stream surgery of the spine. It's endoscopic surgery. At Duke Spine Institute, we stream all of our surgeries live, whether they're endoscopic or open. We still do open surgeries from once in a while. I did a anterior cervical decompression infusion last week. So we do all types of spine surgery here, and we stream all of our surgeries live so people can watch and learn. It's part of our mission to educate the public. All right. That's about it. That's just some fat. But you're all right. I know it's hard to see, and I apologize, folks. It's mostly due to a little bit of oozing coming from the end plates. But that's it. We're done. I'm going to grab that little piece right there of calcified disc herniation, and we're going to get out of this disc.
Lights off, please. Thank you.
Okay, very good. I'm happy with that.
Scope off.
Scope off. The other one. Oh, the irrigation, clear. Okay, we're done at L5S1. Put a little bit of pressure on the muscle as we remove the tube. And the tube we use for the lower back is bigger in diameter than the tube we use for the neck. The lower back tube is 7 millimeters, the neck is 4. So almost double the size as the one we use for cervical, which is the neck, and also thoracic. The tube we use for cervical and thoracic looks like a little metal coffee straw lateral view. And it's just a tiny little metal tube, and we use the same for cervical as we do for thoracic. Let's go lateral, please. Pressure. So we got lucky with L5S1. Let's see if we can get lucky with L45. Go ahead. So what I mean by that is we're able to get in and get it done. A lot of times when it's bone on bone, there's not much disc space. We're taking a space that's maybe 3 millimeters and opening it now to 7. One thing I've seen with the laser surgery too is that we've been able to Is that our view right there? I understand. Let's zoom in a little more. Bring the emitter closer to the patient so I can get a better view. Release the wag. Shot. Does that look better to you guys? Shot. It looks worse to you? Oh, but it is narrow. I'm looking at the pedicles. I'm looking at the pedicle of 4 and the pedicle of 5. That's what tells you the truth. Yeah. Well, we know we did a discogram, so I feel pretty confident about our location. And she had pain. Shot. And this is just a very collapsed space. Let's get something. We may be all right. Let me have it. That's funny. There we go. I think that will do it. Pipe cleaner, clean me a pipe. Are you saying I got in the wrong hole, Luis? Yes? That's what you're saying. The wrong hole. No, that is a problem. Alright, let's get this in the right hole. Lay still. She's a little bit awake. You're doing great. Just lay still. Let me know when I can proceed. She okay? Shot. Shot. I don't know, Luis. Can you give me an AP? Let me just give me 1 second. I'm going to try this. I'm here. Right?
Yeah.
We're in the right spot. All right, lateral. We're right at the disc on the, if you look at the eyes, the pedicles, we're right at the mid-pedicular line. So I'm feeling the disc, but seems a little bit, it's kind of hard to tell because of the way the spines rotate a little bit. So I'm thinking I may want to do it without the guide pin now that I'm under the root. Shot. Yeah, it looks so weird, huh? Shot. I don't know. Okay.
It's going.
Not able to get in. Let's do a towel. This one. Yep. Just want to. All right. Let's do the next one. I'm going to come onto your side.
Yes, sir.
You want to, whoa. You want to
Yeah, let me go there.
just stay where you are.
Yes, sir.
Monica, shot. That's good.
Yeah,
I'm going to have Luis just switch sides.
we need to be careful with him.
What's wrong?
Oh, no. We need to switch the back.
Yeah. Let's put the pedal on my side, please. Yeah. We're getting too old for this. Right? That's what I'm saying. All right. I need a blade. Just about done. We need about 10 minutes on this one, probably 15. It looks like there's a lot of scar tissue. It all depends on what I see when I get in. Shot. But I'm amazed. There's kind of a bigger than I expected herniation here based on the MRI. I mean, I could see it on the MRI. It's off to the side, but her laying this way on her belly, I think is kind of making it push out even more. Shot. 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 Just want to get a little bit further. All right. Nice job. Beautiful. Thank you, Luis. Shot. That's good. Stabilize the tube. Beautiful. Nice job. All right, fluid adapter here. What do they say? Teamwork makes the dream work. Isn't that what they say? All right, let's get the fluoro out. And move that sucker out completely. So we're done with using the x-ray machine to navigate because we've used it for the last time to place our endoscopic tubular retractor into the L3-4 disc on the patient's right side. We know this disc is an 8 out of 10 in terms of its pain that it produced on the discogram. All right. There it is. We'll be done in 10 minutes, doctor. This is all herniated disc material. So when you look at the discogram, okay, we did a discogram, we did the dye in the middle, and it looks like a cotton ball disc. But a cotton ball disc is a normal disc, but this is not normal. So even discograms don't tell you, in terms of the appearance of the discogram, everything there is to know about a disc. This is a condition that's been known for 100 years called internal disc disruption, IDD. And it's the name that doctors have given this condition, where the disc itself looks pretty good on MRI and on X-ray. And even on discogram you get a cotton ball appearance. But it's kind of like a bomb has gone off inside the disc in terms of damage. The disc is just blown out from the inside out. And that may be what is more recently happened for this patient, because when I look at this thing, it's not, the deep part of it here is relatively new injury on the order of months rather than years. Whereas the more superficial part appears to be collagenized, so it looks like she may have injured this initially a long time ago and then healed this disc, and then more recently re-injured it again. But you can just see the bits and pieces of the nucleus just falling off, and it's all staining blue, indicating that it's degenerated. Normal discs don't degenerate. Normal disc doesn't stain blue. Here's the tear. A little bit of collagenization. We're seeing this is the annular debridement, or part of it. The laser is the little glass pipe at 12 o'clock. The blue is the plastic covering over the glass pipe. It's part of the we call the laser fiber. And there's two types of lasers that are used. One is a side firing, where it shoots the laser out of the side, and then the other is straight firing. I like a straight firing laser. I don't like side firing lasers. Side firing lasers hide from the operator. You can't really see what they're getting, what they're zapping, because it's on the side of the laser. This is in the front. You can easily see everything this is zapping. I think it's a safer option with a straight firing laser rather than a side firing laser. So I only use straight firing lasers. I don't use any side firing lasers. But other surgeons use side firing lasers. I tried side firing lasers years ago. 5 minutes, and I just hated it. Not being able to see what I was zapping, and also the power gets diminished with a side firing laser. So you need to crank the power up even higher to get an effect. So more power is not necessarily a good thing when you're inside a human body using a laser. You always want to use the least amount of power you can to get the job done. More power just means more potential for problems. This is that thick band of scar tissue I was talking about earlier when we did the discogram and you couldn't see the tear, because this is kind of partially healed. There's a tear right there. You see the blue? So I don't know if maybe we couldn't see it with the discogram, but there's definitely a tear there. That's right here. That's where all the pain's coming from, is this tear. And the blue stuff is a herniation inside the tear. You can see there's not a lot of herniation inside the tear. It's just a thin streak of blue. So there's a thin amount of herniation. So this would be a skinny herniation basically, or a very thin herniation. But this is one of those herniations at L3-4 in this patient that's deceiving, and a lot of surgeons and doctors are tricked by it because you look at the MRI and you can actually miss it because the disc looks so good. But then if you look off to the side in the foramen, where most radiologists miss herniations is in the foramen. It's called the foraminal herniation. That's the #1 missed herniation by radiologists, foraminal herniation. She has a foraminal herniation at 3-4, and that's what we're dealing with right now. So it's not a herniation in the middle. If you look just in the middle of the spine, you won't see it. You got to look off to the side, and that's what I saw when I saw her MRI. I saw this foraminal herniation. I knew it was trouble based on my experience and the location of her pain. So there's that tear we were talking about. Again, all scarred up like I thought. I knew it was going to look like this when I got to the discogram and I saw there wasn't a big tear, so I knew it was going to be partially healed with a thick wad of scar tissue right at the end. So it must have healed at one point and then somehow she re-injured it doing something. I actually think she's a nurse, and I think she was working, going back to lifting patients and whatnot, and I think she just really re-injured this disc doing that. Stand by. So you can see she actually had a problem at this disc years ago, and it scarred over and healed. Probably wasn't painful for her. And then I think she re-injured it recently because I could see a new tear. If you watch our video, hey, why don't you run that video again, Diego?
Yes, I'm running it.
And show that how an annular tear forms and how the herniation goes into the tear and causes pain and inflammation, and how they can re-injure that later on.
Traumatic injury on the disc can
And that's
cause
what I think
annular
she did
tears
with
to
this
form.
disc. This disc in particular. You can see the tear right there.
Pressure on
Almost
the
done.
disc causes herniation
another
of the
few
nucleus
minutes to go.
pulpus through the annular tear.
I thought we'd be done, but this outer part is a lot more collagenized than I thought it would be.
Inflammatory tissue develops
Taking
within the
longer
annular
than I thought
tear,
it would
causing
be,
neck
which is
pain.
fine.
The inflamed annular tear generates pain
She's gonna be
signals.
very happy, I think, with her results. Now, she's having a cervical RFA tomorrow.
Additional injuries
because
can
she
cause
has
worsening
Facet
symptoms.
syndrome as well in her neck. So we're going to help her with that.
Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing
my
localized neck
irrigation.
pain.
The irrigation is important. All right, pressure's good.
Pain signals reach the
Then
primary
give 'em,
somatosensory cortex,
bubbles and
causing
debris.
conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at
kinda cool when you go back and look at this
www.mri.dukespine.com.
You'll see what a disc that's healed looks like. And then she's got just that thin little stripe of reherniation and re-tear and reherniation. All right, we're pretty much done. Scope off. Great work, everybody. We're all done. You did great. Man, I love that anesthesia. When the patient wakes up right when you're done. That's the best anesthesia you can get. That's what I'm talking about earlier. That was another thing. My patients at the hospital with the nurse and us, they would literally, this is what's crazy. Because the nurse anesthetist needs the anesthesiologist to recover the patient, if the anesthesiologist was busy somewhere else, they would keep the patient asleep. Sometimes for an extra hour, hour and a half after I'm done. And they would just lay there asleep, waiting to extubate till the anesthesiologist was available. But the anesthesiologist is doing an emergency hysterectomy or what do you call it, a C-section. Ape shit. Are you kidding me? It's not good for the patients to be laying there intubated under general anesthesia for an extra hour. Yeah, yeah. Which I wasn't worried so much about that because I've never done that, but just, yeah. But just the time under anesthesia is not good. The fluids, you know, the fluid status, overloading the lungs, and that's why I get so much pneumonia in my patients. It was crazy. Just laying there. You're all done. You did great. Come out. Just don't go past the sterile barrier. Just lay still, you're fine. That's just the sticky stuff, the tape. You're fine. All right, so she had 2 incisions, both 7 millimeters. Beautiful. Just put pressure for 1 more minute and you're good. Thank you. Everybody, thank you. Great work. Ray Tech off. Great job today. Thank you. Yeah, that was a long day. All right, if you have questions, type them up. I'll be happy to answer them for you. We're just wrapping up a live laser spine surgery at Duke Spine Institute for 2 degenerated discs and 1 herniated disc that you can tell has been re-injured multiple times. I'm going to call our EBL 7 mil. Let's get started. I'm Dr. Duke Majan. We're here with one of our patients who traveled to here from Texas, correct?
No, Auburn, Alabama.
Sorry, Alabama. All right, so Alabama. And why did you come to Duke Spine Institute?
Because the last flare-up of L4 that ruptured in 1999 was unbearable, and my wife can be a testament to that. Who took care of me for 10 days, crying on the floor, with an amazing, incredible pain.
Okay. And you've had that pain now in your lower back for 22 years.
Yes.
You've tried physical therapy and exercises, stretching, but none of those things worked.
No, temporarily.
Yeah. And where was your pain coming from? Do you know?
It was around the belt region in the back. Yeah.
So the L45 and L5S1 discs had tears and they had inflammation and pain. He also had sacroiliac joint inflammation and pain. And Dr. Patel standing here, which we don't get to see you very often, but Dr. Patel was a hero. He came in and did the bilateral SI joint injection.
Yep.
So do you still have the pain in your back that you came here with?
No.
It's gone.
It's very, very gone. Yes.
Excellent. Well, it should stay gone. Is there anything you want to say?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com. Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com. Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain.
You're live right now.
We're live?
Yep.
All right, we're all done. Our patient had a lot done today. She had a sacroiliac joint pain and facet pain on the left and at L45, L5S1. She also had 2 degenerated discs, L45, L5S1, that we were able to fix L5S1, but I couldn't get into the L45 disc. It was just 2 collapse and 2 stuck down. And then we fixed the L3-4 disc on the right side. So everything went well, except we weren't able to do the 4-5 on the left completely. But I think we'll probably get 90% of the pain, maybe more if we're lucky. Just depends. A lot of times when discs are so stuck down, they don't move much. They don't cause really that much pain. That's what fusion does. I wouldn't say it's fused, but I'd say it's close to it. Just from all the inflammation over the years, I think it's pretty close to being solidly fused, but I don't think it's fused just yet. It's pretty close. That's why I couldn't get the bones apart. All right, so she's waking up, and I'm happy with the way surgery went. What questions do we have?
That was the only one. Were you able to fix the middle one?
Yeah, I was not able to fix the middle disc. I couldn't get in, so there's nothing else we can do about it. We're going to leave it alone and see how she does. All right, hopefully you enjoyed the surgeries today, and we'll be back next week, I think, for more surgery. And you're updating the calendar, right?
Yeah.
So people know what we have for next week.
Mm-hmm.
Enjoy your evening. Thanks for joining us. I'm Dr. Duke Majan, over and out from Duke